audible? Can you all quickly give me a thumbs up if my audio video is fine? We have a lot of interesting sessions or questions which is planned for today. It will be a long session where I will be discussing some PYQs, which is very, very important for all of you to know. So let me introduce myself. I'm Dr. Chesta Agarwal, your NEET PG educator on the best online platform, that is Unacademy. On Unacademy, we provide two type of subscriptions. One is Plus, which give you an access to Unacademy live classes, and Iconic give you an access to both Unacademy and Prep Ladder. Now, we have recently introduced the Unacademy notes. We have recently introduced the Unacademy notes, where you get the notes of all the 19 subjects based on the classes of the top educators. So they are made from the classes of the top educators for their respective subjects. Now, here, if you take, you also have 1 year subscription free. The duration will be a 12-month plus 2 month, which is around 27 550. If you use my code Chesta10, you will get additional 10% discount. So these are the price listed for all of you. Please remember this is valid, or the offer started from February 23, and only the first 1,000 subscribers will be benefited from the Unacademy notes. The price hike is also announced, so I request all of you to kindly use this code Chesta10 and get your subscription today. Otherwise, the prices will go up. I also tell you that there are two type of subscription. One is Plus, which give you an access to Unacademy live classes, and we have Iconic, which give you an access to both Unacademy and Prep Ladder. I congratulate to the toppers of FMG, those who have cleared this exam, as well as this is the final announcement of the test which we have scheduled for this month. We do take a lot of free live classes on the platform, and today I have a free live class at 1:30 p.m. That is a crash course of dermatology, requesting all of you to please be a part of this session. New batches are about to start. This is the announcement for that. We are starting with a NEET PG PYQ session, which is of 2 months. Humble request to please attend this batch because you will have a lot of information. All the top educators you can see in this list, all the top educators are the part. We also have a FMG 2022 comprehensive batch starting on March 2 and extending to March 2. We have FMG batches which is of 9 months. This is for 2022 November exam. And then we have a next year exam which is target next. Again here the amazing educators will be the part. Requesting each and every one of you to go ahead and get your subscription. We have also introduced the one of its best NEET PG All Educator Revision batch, where we have 40 plus educators all in one batches, 130 plus hours of revision, 8 grand tests, and 19 subject wise tests. This is the price list. Again, the same code. You can use my code Chesta10 and get your subscription today. Remember that price hike can go very, very soon. Okay. Okay. Now moving to the next question. Again, JJ, I'm not very much sure about your question. You have to go and check with a local doctor for that. Uh, it depends upon the frequency and everything, and I think it's a good subject. Everybody can take it, but specifically if somebody has tremor issues, it would be best if you go and meet a doctor physically for its severity. Wood's lamp is not used for diagnosis of vitiligo, porphyria, pityriasis, or lichen planus, where we will never use a Wood's lamp as a diagnostic modality. Wood's lamp is not used for diagnosis of. Amazing, all of you. Very nice. Now, Wood's lamp is what? It is a handheld instrument which emits UV radiation. Now, just look at this image. I want all of you to have a look on this image. You can see that there is a rectangular box which is present, and there is a handheld part which you can hold, and there's a wire which is connected here. Now, this wire will actually give the electricity source, and there's a button here. When you start this button, the undersurface of the instrument, they have UV bulb, and they will have a filter also, which is made up of barium silicate and nickel oxide. So because of this filter, the UV radiation which is emitted, they only belongs to 365 nanometer. Now, when this UV radiation falls on the tissue or the organism which possess the property of fluorescence, they will emit a light of a longer wavelength. And that light which is emitted back from that tissue can be easily seen under the visible spectrum. So depending upon the site, we have different colors. For example, in tinea capitis, we observe bluish green color. Erythrasma, we see coral pink. Pityriasis versicolor, we see faint yellow. Pseudomonas, it is green. For scabies, we see fluorescent solution in the burrow. For porphyria, we see red urine. And for vitiligo, we see ivory, milky white color. You can see it here also in the image. For vitiligo, there is a very characteristic ivory white color, and for erythrasma, it is coral red appearance. In lichen planus, we do not have any property of fluorescence, and that is why lichen planus cannot be distinguished or cannot be or wood slime cannot be used for diagnosing lichen planus. You have to do a biopsy to look for the lichen planus and related features. Moving to the next question about the Langer lines, which of the following statement is true? About the Langer lines, which of the following statement is true? Remain constant throughout the lifetime of a person, corresponds to the collagen fibers in the dermis. Incision along these lines produces a better scar, and skin along these lines is least flexible. What is the correct answer here? Very simple question from the basics. Anybody can tell me the answer? What is false about Langerhans lines? Now, please remember, Langerhans lines, they keep on changing in the lifetime. It's not constant. What are these lines? Anyone? Please remember these lines, they correspond to the collagen fiber arrangement in the dermis. These are the incision along these lines which produces a better scar, and skin along these lines, they are least flexible. So just look at this picture. These are the Langer lines which are directed along the collagen fibers, along the lines of the collagen fibers. Clear all of you? Moving to the next question. Anybody can tell me the answer here? They are dynamic lines. It means they keep on changing. They are not same. They keep on changing. They are not same. What is a zinc cell? What is a zinc cell? Anyone? Oh, very nice. Now please remember, zinc cell, it is nothing but a keratinocyte. Now usually if these are the keratinocytes, if these are the keratinocytes, they are attached to each other with the help of a glue. So that is a glue. This red color is the glue. They are attached to each other with the help of a glue. But sometimes what happens, this glue is lost or damaged. These cells get separated like this. And then they are known as acantholytic cells or zinc cells because you do a zinc smear to look for it. Acantholytic cell or a zinc cell because you do a zinc smear to look for it. So actually these are nothing but keratinocytes which have lost its attachment from the surrounding skin. They are the round shaped cell. They have lost its attachment from the surrounding skin. So that is the difference, very, very important. Now here if you see, when you do a zinc smear, you see the keratinocytes like this. They are round with a large nucleus and a perinuclear halo. Round cell, large nucleus and a perinuclear halo. Clear all of you? Next question is on your computer screen. Which of the following is not present in stratum basal layer? Which of the following is not present in a stratum basal layer? Anybody can tell me the answer. Anyone? Can you tell me the answer here? Which of the following cells is not present in the stratum basal layer? Please remember, we have three structures of the skin, that is epidermis, dermis, we have epidermis, we have dermis, and we have subcutaneous tissue. Epidermis is further divided into different layers, and the cells in these layers are nothing but a keratinocyte. The cells here are nothing but a keratinocyte. Now, other than keratinocytes, we have three more cells which you see in our epidermis. These are Merkel cell, melanocytes, and Langer cell. We have Merkel cell, melanocytes, and Langer cell. Langer cell, which is a mesodermally derived cell, it is present in the stratum spinosum. Melanocyte, which is a pigment forming cell, it is present in stratum basal. And Merkel cell, which is a touch receptor, it is present in the stratum basal again. Is this clear to all of you? The question is, which is not present in the stratum basal layer? Which is not present in the stratum basal layer? Please remember the answer is Langerhans cell, because Langerhans cell is situated in the stratum spinosum layer. It is situated between stratum spinosum layer. Okay, so this is a very interesting image which shows different layers. I hope this is clear. It's a very different, very classical image. So you can see here that all the layers have keratinocytes. In stratum spinosum, we have Langerhans cell, and in the stratum basal, we have these are the keratinocytes. Then we have melanocyte, and then we have Merkel cell. So only cell which is missing in the stratum basal is the Langerhans cell. Okay, next question is here on your screen. Identify the condition: target lesions, macule, pustule, or a nodule. Identify the condition. Identify the conditions: target lesion, macule, pustule, or a nodule. Very nice. Now here, if you just zoom this image, you can see that we have some concentric circles. At the center, it is little darker. Then we have a lighter ring. Then we have again a red ring. So this is a very classical target lesion which you see in the patients of erythema multiforme. You see it in the patients of erythema multiforme. Next question. Okay, before telling you the next question, just remember what are the three layers, because you sometimes get the question. The central is the necrotic zone. So just remember the center is made up of a necrotic zone. There is a necrotic center. Then you have a edematous zone. You have edema. And then you have erythema. So these are the three layers. Okay. Now next question. Elevated clear fluid filled blisters of size 2 centimeter would be classified as Naveen, the budding FMG, Niveda, Jyoti. What is the correct answer here? The elevated clear fluid filled blister of size 2 centimeter would be classified as macule, nodule, vesicles, and blister. They have clearly mentioned that it is a fluid filled blister. If it is less than 1 centimeter or zero point 0.5, it is known as a vesicle. And if it is more than 1 centimeter, it is known as a bulla. So look at this image. This is a diagrammatic representation of a vesicle and a bulla. You can see that bulla is large, more fluid. And on the right, you can see this tiny fluid-filled vesicle. And here you can see a large fluid-filled bulla. So that is how a vesicle and a bulla appears. We have a lot of conditions which presents as vesiculobullous lesions. Like we have a whole group which is the autoimmune vesiculobullous disorders like pemphigus, bullous pemphigoid. Then infectious conditions like bullous impetigo, staphylococcal scalded skin syndrome. They all can have these vesicles and bullae present in them. Moving to the next question, loss of intercellular cohesion between keratinocyte is called as. What is the correct answer now? Anyone can tell me the answer here? Loss of intercellular cohesion between keratinocytes, they are called as. Very nice. Now, I have mentioned the same thing few minutes back when we were discussing about the zinc cell. So what is happening? The intercellular connections are getting lost and the keratinocytes are getting separated. That process or that phenomena is known as acantholysis. Lysis means separation. Separation, and acantha means the separation of the keratinocyte, specifically of the stratum spinosum layer. Now, this is how the normal skin looks like. Like if I take a biopsy and if I do a histopathological examination, you can clearly see this is, let me zoom it for better understanding now. I think you can see it much clearer now. Can you see this thin flattened cells which is present in a basket weave pattern? This is stratum corneum. Just beneath this, you can see a dark color layer. Can you see a dark color layer just beneath it? Can you see a dark color layer just beneath it? This is very, very important. What is this? This is stratum granulosum. This dark color layer is stratum granulosum. Just beneath it, you can see a thick layer which is stratum spinosum, and the last single columnar cell layer is stratum basale. This is how the normal skin look like. But if I compare this part with this part, or where is that image? This is how a abnormal skin look like. Can you see so much of thickness of the stratum corneum? There's a lot of nucleus. This is how the abnormal skin looks like. And same thing when there is separation, where there is a split at the epidermal level, you will call it as acantholysis. Now let's answer this. Which of the following layer contain abundant desmosome? Which of the following layer contains abundant desmosome? Which of the following layer consists of abundant desmosomes? Which of the following layer consists of abundant desmosome? A, B, C, or D? Complete histopathology based question. We have a lot of images attached here. So what is the answer? Which of the following layer contain the abundant desmosome? Very nice, Naveen. The budding FMG, Nivita. Now, if you talk about layer number one, it is stratum corneum, which we have discussed. This one is, you can see it's small granules. So this is stratum granulosum. The B, that is the whole thickness till here, is stratum spinosum. Number C is stratum basale. And number D is dermis. Let me just elaborate this for you. Look at this. Stratum corneum. Then this is a granular cell layer, stratum granulosum. Then this whole thickness is stratum spinosum. And can you see at the lower level? Can you see at the lower level we have single columnar cells with some pigment, because the melanin is seen only at the stratum basal level. The pigment is getting produced in the melanocytes which are present in the stratum basal. So C is stratum basal and D is obviously dermis because it is present beneath the dermoepidermal junction. Please remember the maximum desmosomal interconnections, they are seen in the layer. Which layer? In stratum spinosum. And what is the reason behind this? Because of more layers, you have more intercellular connections, and that is why you have more desmosomes which you see in these individuals. Clear all of you? So I think it's a very easy one. No confusion with this question. Now moving to the, okay, so I was talking about acantholysis, right? So I was looking for this image only. Look at this image, a very beautiful image. This is how the normal skin, this I've drawn myself. So just look at this. This is the flattened stratum cornea. This is granulosum. Now just beneath it we have stratum spinosum and the lowermost is stratum basale. Now whenever there is loss of intercellular connections, the cells get separated like this. Can you see the cell gets separated like this? And these separated cells are known as acantholytic cells. These separated cells are known as acantholysis cells. And what is this procedure called as? This phenomena is known as acantholysis. I think it's very well clear here that what actually happens, what is acantholytic cells with the help of this image. Moving to the next question, what is the treatment of choice for nodulocystic acne vulgaris? What is the treatment of choice for nodulocystic acne vulgaris? The budding FMG, Naveen, all the other students. What is the treatment for nodulocystic acne vulgaris? Nodulocystic acne vulgaris, what is the treatment of choice? Amazing. Now please remember we have four grades of acne. We have four grades of acne. Grade 1 is a comedone. Grade 2 is papule. Grade 3 is pustule. And grade 4 is nodulocystic type of acne. So I'm just writing it here for everyone. You do get a lot of questions on them. So I've thought of putting all this together. Comedone. Then what is next? We have a papule. What next? Comedone, papule. Then we have a pustule. Then what else? We have a nodule. Now, if you look at this image, let me tell you that the treatment of choice, if they ask for comedonal stage, is treatment of choice for a comedonal acne is you have retin, which is the topical retinoids. Topical retinoid. For papules, it is the topical antibiotics, which is clindamycin or Depson gel or nadifloxacin. Pustular stage, oral antibiotic becomes our first choice. And for nodular stage, oral retinoid, that is isotretinoin, becomes our treatment of choice. And here this is the grade 4 acne, so the answer becomes option number. Is this clear to all of you, Naveen and all the other students? The correct answer of this question is option number 1. What is acne vulgaris? It's a disease of pilosebaceous unit. Now just have a look on this image. What is a pilosebaceous unit? So pilosebaceous unit, it has hair and sebaceous gland. Both of them together is known as pilosebaceous unit. Now what happens? Can you see this part, this white color? This is actually the sebum which is produced by the sebaceous gland. It usually enters the hair follicle and through the hair follicular opening it comes out and gets distributed on the skin. So this is the hair follicle, this is the hair follicle, this is the sebaceous gland and this is the duct through which the sebum is coming on the skin. Sometimes what happens that this outflow gets obstructed. So look at this image now, very beautiful image. The outflow get obstructed. You can see that there is sealing of the outflow with the help of a skin. And because of which the sebum which is being produced, it is not coming out. It gets accumulated inside the hair follicular unit. This is known as a comedone, and because the color of the sebum is white, it is usually known as a white head. It is usually known as a white head. Budding FMG, definitely I'll tell you the grades, but just give me a few minutes more. I'll tell you everything. Okay, so this is a grade 1, that is comedone, which is a white comedone. Sometimes there is no complete sealing of the skin, and the air enters, oxidizes the sebum to black. This is known as blackhead or open comedone. So remember that the comedones, whether white or black, this is the grade 1. Please remember, budding FMG, the grade 1 is the comedones, whether it is black or white. Now, we all know that we have a bacteria which is present in the hair follicle, which is Propionibacterium acne. This Propionibacterium acne will then start proliferating. So, the next grade, you can see it here. In the next stage, papular stage, there is a lot of P acne which is getting proliferated. So, this is the grade 2. And now, because of the proliferation of P acne, the body starts to send the inflammatory cells at the site. So you can see it here. There is a lot of white blood cells giving rise to grade 3, that is pustule. Budding FMG, is it clear till here? So the grade 1 is presence of comedone, grade 2 is a papule, grade 3 is a pustule. And ultimately what happens? Because of so much of collection, this will rupture to form a nodule and a cyst, which is a grade 4 of acne. So that is the normal pathophysiology of acne vulgaris. And again, for those who have missed, the grade 1 is a comedone because the main problem is the obstruction to the outflow. So the treatment becomes the keratolytic drug. Second is a papule where the Propionibacterium acne is actually proliferating. So we are giving topical antibiotics. In a pustular stage, what is happening? In pustular stage, we have more and more of inflammatory cells, so we need an oral antibiotic to work. And for a nodule, we have to give something which take care of excessive inflammation, which take care of sebum secretions and everything. So you have to give a drug which is nodulocystic acne, treatment of choice, oral isotretinoin. So that's all about the today's session, and whatever I've told you, it's given here, the grade 1 treatment, 2, 3 and 4. Next question, let me really quickly shift the image so that it becomes more visible to all of you. Now, amazing. I hope you can see this question. A 20-year-old male presented to derma OPD with a multiparous comedones. We have an intercommunicating abscesses cyst with a serosanguinous fluid or pus. Which of the following statement regarding the underlying condition is true here? Usually associated with flushing and intolerance. I request all my students, if you want to learn the whole dermatology with simplified images, with a lot of mnemonics, please join my plus course on Unacademy app. For taking any subscription, if you use my code, that is CHESTA10, CHESTA10, you will get an additional 10% discount on this. Okay, so please go ahead and get your subscription today. Watch all my classes where I explain the dermatology in detail. A 20-year-old male presented to dermatology OPD with multiparous comedone. We have intercommunicating abscesses, cyst with serosanguinous fluid. Which of the following statement regarding the underlying condition is very nice, all of you? Naveen, the budding FMG, very, very nice, all my dear students. So here the answer is option number 2. And let me explain what is acne conglobata to all of you. Okay, so for this you need to know the different types of acne, and I think I've somehow lost that slide. So what are the severe forms of acne? There are two forms which everybody needs to know. One is acne conglobata and another is acne fulminans. What is common in both of them? They both will have a very characteristic presentation of nodule and cyst. Both of them have this same thing. They have nodule plus cyst. They have nodule plus cyst, which is more on trunk compared to the face, which is more on trunk compared to the face, or equally on face and trunk. Okay, usually acne vulgaris is not that common on trunk, but here it is. Even on trunk you can see the lesions of nodules and cysts. Now what is difference, or what is the main difference between them is, in acne fulminans you have an additional constitutional symptoms like fever. You will have a lot of constitutional symptoms in these individuals. You have a lot of constitutional symptoms like fever, malaise, then arthritis, leukocytosis, etc. But there is no such constitutional symptom at acne conglobata. And if you discuss about the treatment part, it is oral iso, no oral. The treatment is oral isotretinoin. While the treatment in acne fulminans is always oral steroids, if you give oral isotretinoin, it can even precipitate the condition. It can even precipitate the condition. So please remember the treatment also differs and the presentation also differs. Here you only see some intercommunicating abscesses, nothing about fulminans is mentioned. Option number 1 is incorrect because that is a feature of acne rosacea. If it is acne conglobata, then option number 3 and 4 is also wrong because oral isotretinoin, not topical retinoid. It is the oral retinoid which becomes the treatment of choice. Moving to the next question. Identify the following symptoms: Baker's nevus, hypopigmented macule, spitz nevi, or epidermal nevus. Identify the following lesions. Identify the following lesions: Baker's nevus, hypopigmented macule, spitz nevus, or epidermal nevus. Very nice. I think it's a self-explanatory image. It is a case of Baker's nevus. It is an epidermal melanocytic proliferation which has androgen receptors on the nevus cell. Because of the same, the lesion or the nevus increase in its size during puberty. They can have an associated hypertrichosis, and you can even see the acneiform eruptions on them. Very nice. It is a case of Baker's nevus. Now, one of the option is Spitz nevus. Please remember it's a benign condition. It is not a pre-malignant or malignant condition. Initially, we used to confuse Spitz nevus with melanocytic melanoma or melanocytic melanoma, but now it is proof that it is a benign condition with a very characteristic bodies inside them, which is known as camino bodies. So this is a very classical Spitz nevus. Next question is on your screen. What is the answer to this question? Which of the following medicine taken during pregnancy is responsible for the defect seen in this child? Which of the following medicine taken during the pregnancy is responsible for the defect seen in the child below? Ferrous sulfate, isotretinoin, folic acid, metoclopramide. Anyone? I think it's an easy question. The answer to this question is isotretinoin. So please remember, isotretinoin is a teratogenic drug. When it is taken during pregnancy, it can cause the defects like cleft lip and cleft palate. So we have a lot of side effects. I request all of you to please write it down. This is a very important chart. First of all, remember that it is a 13-cis retinoic acid. It is a 13-cis retinoic acid where you have dry skin cheilitis, you have raised LFT triglyceride. You can develop a very rare side effect which is known as diffuse idiopathic diffuse idiopathic skeleton hyperostosis. diffuse idiopathic skeleton hyperostosis. We have a feature which is known as pseudotumor cerebri. It is also one of the side effects of isotretinoin, and this can also be seen with tetracycline group of drug. And that is the reason we never combine a oral retinoid with that of oral tetracycline group, because both of them will have the same side effect. And in the end, we have teratogenicity. We have to keep in the mind whenever we give isotretinoin in a reproductive age female, you have to counsel the patient not to get pregnant. Repeated urine pregnancy test should be done. What else can be done here is you should have at least a strict contraception for 1 to 3 months after stopping the drug. If somebody is planning for pregnancy, at least 1 to 3 months of drug free interval should be given, because it is a water soluble drug which takes around this period to get completely washed away from the skin. Okay, and here you must not be seeing it is increase in LFT and triglyceride. Okay, this part which is not seen behind me, here it is LFT and triglyceride levels. There are many more side effects of isotretinoin. We have discussed about the dryness. So you can have cheilitis, dryness of nose, dryness of eyes. A very rare side effect is you can have dryness of the cornea, which can give rise to decreased night vision, followed by corneal opacities. You can get photosensitivity. Why it is rare in Indians? Because we have already a pigment on the skin. The Western people, they are lighter in color, so it is more photosensitive in them. Patients can develop headache, the reason we have discussed, because of pseudotumor cerebri. Hair loss is also indicated or is seen. Alopecia is also seen. Hyperostosis, it is a dose dependent. And please remember, you never extend beyond 120 to 150 mg per kg per day. If you extend beyond this, the rarer side effects of dish, of all these will start. Triglyceride levels, they are elevated, so you have to take care of it. Cholesterol levels can also be increased. Liver function tests get deranged. You can have muscle pain, teratogenicity, and please remember depression and suicidal ideation. There was once a student who have asked me that, ma'am, why isotretinoin is contraindicated in pilots. So maybe that could be a reason, because it has a little bit of suicidal ideations which can be developed, and we can never take a risk of having the same in a pilot or a driver or anything like that. Okay, so that could be a reason for the same thing. Now coming to the next very important question. 18-year-old girl with who presented to dermatology OPD with complaints of acne. Dermatologist prescribed few topical agents. Along with that, he advised dietary modifications like avoidance of high glycemic index food and dairy products. What can be the plausible logic behind this? What can be the plausible logic behind this? Amazing. Naveen, budding FMG, very nice, all of you. Amazing, all of you. So I think this is a very interesting thing. So 18-year-old girl who presented to Derma OPD, 18-year-old girl who presented to Derma OPD with complaints of acne. Dermatologists prescribe few topical gels. Along with that, advise dietary modifications like avoidance of high glycemic index food, dairy products. What is the plausible logic behind it? Why somebody advise a dietary modification in form of high glycemic index food? Please remember, these food agents like dietary products or dairy products or high glycemic index food, they tend to increase insulin-like growth factor. And insulin-like growth factor actually causes stimulation of sebum production. So obviously, if the sebum production increases, the chances or the risk of formation of acne also increases. So that could be a cause in this particular patient why the IGF is increased. Okay? I hope this is clear to all of you. What is Cox peculiar tumor? What is a Cox peculiar tumor? What is the Cox peculiar tumor? Anyone can tell me the answer here? Very nice. What is a coxpicular tumor? It is nothing but infected sebaceous cyst. This I think a lot of you must not be aware of. So what is infected sebaceous cyst? You can watch it here that there is a large sized or a wide spaced ulcer which is present on the skull. A wide based ulcer. This is a epidermoid cyst which consists of keratin. It mainly occurs because of invagination of the skin or the keratinocyte deeper in the skin, which stimulates the formation of keratin and forming this. So this epidermoid cyst, it gets infected. There can be any source of infection here. So it gets infected and it can give rise to formation of the Cox peculiar tumor. What is the name given to the solid lesion of less than zero point 0.5 centimeter? Less than zero point 0.5 centimeter. What is the answer here? Name the solid lesion of more than, oh sorry, it is more than zero point 0.5, not less, more than zero point 0.5. Anyone can tell me the answer? The name of the lesion which is more than zero point 0.5. I think it's an easy one. The answer to this question is a nodule. A papule is a solid lesion of less than zero point 0.5 centimeter, while nodule is a solid lesion of more than 30-year-old male presented to dermatology OPD with complaints of patches of hair loss without scaling, erythema, and palpitation. The resident noted exclamatory hair at the edges of the patch. Which of the following are the poor prognostic factor of the plausible diagnosis? Early onset, associated history of atopy, widespread alopecia, or all of the above. Which of the following is the correct answer here? 30-year-old male with history of associated history of atopy, widespread alopecia. Which of the following is correct here? Very nice. Can you tell me what can be the diagnosis first? First, tell me what can be the diagnosis. A lot of history is given. If you know the diagnosis, everything becomes very easy. It is a case of alopecia areata. Amazing. It's a case of alopecia areata. This is clear from this question. What is alopecia areata? It's an autoimmune disease which affect the anagen hair bulb. So we have T lymphocyte which is directed against the hair bulb of anagen. Now it causes damage to the hair and cause patchy hair loss like this. Can you see very well defined, very well defined alopecia patches? Now what exactly happens here is, I need a blank paper to explain that. Okay. So suppose this is an anagen hair. You all know that there is an anagen hair which is present in the hair follicle like this. So this is the block of the skin, dermoepidermal junction. This is an anagen hair. Now, in anagen hair, at the bulb area, you have pigmented cells against which the body develops T lymphocytes. Against which the body develops T lymphocytes. Like this. Can you see it here? Like this. Now, what happens because of the damage or because of so many T lymphocytes, the hair starts to get thickened, thinned, not thickened, they start getting thinned. So this was the initial stage, and what happens later is hair becomes like this. You will see that there is tapering of the hair which started. Okay, so initially it is like this, but now hair becomes tapered, and this tapered hair is known as the exclamatory hair. This accumulation of T lymphocyte, this is known as swarm of B. Accumulation of this T lymphocytes is known as swarm of B. Why it is known as swarm of B? Like a madhumakhi ka chatta. This is the hair and so many T lymphocytes. It appears as if you have a lot of bees around a wood stem. Swarm of bee appearance. Swarm of bee appearance. Please remember, early onset, widespread lesions, history of other autoimmune conditions, they are all the poor prognostic factors for alopecia areata. So the answer to this question becomes all of the above. The answer to this question becomes all of the above. I hope nobody have any confusion with respect to this question. If you have, do ask me. I'm assuming that no one has any confusion. If you have, please do ask me. Very nice. Next question is on your computer screen. Naveen, the budding FMG. All of the following are non-cicatricial alopecias except alopecia areata, ectodermal dysplasias, androgenic alopecias, or pseudo-pallid of Brugge. All of the following are non-cicatricial except. So you have to tell me which is the cicatricial type of alopecia or scarring type of alopecia. I hope you know what is cicatricial. Cicatricial means scarring type. Very nice. Very nice. So all of the following are the non-cicatricial type of alopecia except the answer is pseudopelade of Brugge, which is actually an idiopathic cicatricial alopecia. And the classical clinical lesion which you see is footprint in snow or footprint on snow appearance. As if somebody is walking on the snow and the footprint which you develop. So that is a very classical lesion. Now just write what are the other examples. So you may get this question, the examples of non-cicatricial and cicatricial. Non-cicatricial, cicatricial, we have 3A and 3T. Okay, so 3A is androgenic alopecia, then alopecia areata, and anagen effluvium. Anagen effluvium. While 3T for non-cicatricial or non-scarring is telogen effluvium, trichotillomania, and tinea capitis. So we have androgenic alopecia. Let me use a different color. Androgenic alopecia. We have alopecia areata, and we have anagen effluvium. Anagen effluvium. For telogen effluvium, for T we have telogen effluvium. We have trichotillomania, and we have tinea capitis. While for cicatricial, we have lichen planus, we have DLE, morphia. What else we have? DLE, morphia, pseudopelade of Brugge, then inflammatory tinea capitis. All these are the examples of inflammatory tinea capitis. So please write it down. These are some of the important questions which you might get in your exam. Okay, and the answer to this is option number 4. Next question is on your computer screen. Very quickly, I request everyone to tell me the answer. Very nice. The patient comes with the history of bulla of more than 90%, 30% of the body surface area. Very similar question we have discussed in the past. This has to be a case of 10, which is toxic epidermal necrolysis. It is a 10 necrolysis, and drugs is the commonest etiology for this. Denny Morgan fold is indicative of dermatitis herpetiformis, atopic dermatitis, leprosy, or TB. Denny Morgan fold is indicative of. Denny Morgan fold is indicative of. Amazing, all of you. Denny Morgan fold is indicative of. This is a minor criteria. Please remember, it is a minor criteria for atopic dermatitis individuals. Minor criteria for atopic dermatitis individuals. Most common cause of plant-induced dermatitis in India. This was a recent FMG paper question, or it was a other way around question. But first of all, you tell me the answer, then we will go ahead. Anyone? The most common cause of plant-induced dermatitis in India would be. Plant-induced dermatitis in India would be. Anybody can tell me the answer here. Amazing, all of you. It is the Parthenium plant-induced uh, allergy, and Parthenium plant, it is scientifically known as Parthenium hysterophorus. Just look at this image. We got the image also this year in FMG paper. So it's a wild plant with the white flowers on them. It's a wild plant with white flowers. And the allergen which is present here is sesquiterpene lecton. The allergen is sesquiterpene lecton. It causes a very specific type of allergy, which is mainly on the exposed part or on the skin creases. You can see it here on the creases of the skin and on the exposed part of the body. Okay? Yes, there was a image-based MCQ which we have seen. Moving to the next question. Moving to the next question, everyone, Naveen. Then we have other students, a lot of students, Jyoti, Nivita, budding FMG. The child, after taking medicine for fever, presented with the following picture. Which of the following is the answer? Very nice. Good. Again, we can see that there is crusting on the lips with targetoid lesions. Crusting on the lips with targetoid lesion. Very, very well defined. It has to be a case of Steven Johnson because we have targetoid lesions. In erythema multiforme, we have target lesions. So there's a difference between both. So here we have targetoid. Only two zones are seen. So the answer becomes Steven Johnson syndrome instead of the other two. In which of the following option, the following types of conditions are seen? I'll tell you the diagnosis. It is parakeratosis pustulosa. So what is common in parakeratosis pustulosa and anything common in this condition and the other four examples? Anything common? In which of the following option, the following type of conditions most frequently occurs? Actinic keratosis, basal cell carcinoma, seborrheic keratosis, or molluscum contagiosum. Very nice. The answer is option number one. Please remember, parakeratosis is a feature of seborrheic dermatitis, not seborrheic keratosis. Okay? Seborrheic dermatitis, not seborrheic keratosis. Actinic keratosis will have a clear-cut parakeratotic lesions or a parakeratotic appearance. Next question is here, a 25-year-old girl with erythematous papule on the face. The lesions were exacerbated on excessive sweating, sun exposure, and emotional disturbances. What can be the diagnosis? What can be the diagnosis? Very nice. Good. This is a case of acne rosacea. There is exacerbation on sweating, sun exposure, emotional disturbances, all these aggravating factors. This help us in differentiating rosacea from other four differential or other three differential diagnoses. You will never see any exacerbation secondary to these triggers in SLE, even in photodermatitis or acne vulgaris, but it is very characteristic of acne rosacea. In acne rosacea, microorganism also plays a great role, that is Demodex. Others like Bacillus oleronius and H. pylori. We do get vascular abnormalities. We have environmental changes, which are the triggering factors. In addition, spicy food, alcohol, stress, angerness, or angerness is also one of the precipitating factor. Now we have total four type of presentations. One is erythemotelangiectatic, where you have erythema and telangiectasia. We have a papulopustular variety, where you have a papule and a pustule. Then we have a phymatous variety, where you have thickening of the nose, phymatous rosacea. And then we have an ocular variety, which is known as ocular rosacea. So all of these features, the erythemotelangiectatic, papulopustular, phymatous, or ocular rosacea. Only last 5 minutes is left. So very quickly, photosensitive dermatitis would be all except the last 5 minutes for the today's session. Photodermatitis is a feature of all of the following, or you have to pick one option which is correct. Very nice. The answer is option number 2, pellagra. In pellagra, you see photo exposed rashes, the areas on the photo exposed areas. It is not for pemphigus, has nothing to do with the acne prone lesions. Please remember this list. The disease is related to photosensitivity. It is actinic folliculitis. Actinic word, wherever it is present, it is a sun-induced lesion. Then we have some genodermatosis like Bloom syndrome, Darius disease, dermatomyositis. We have lupus erythematosus. We have pellagra. We have few cases of pemphigus also. Then we have pseudoporphyrias, etc. Clear? So the answer to this question becomes option number 4. So even psoriasis and pemphigus patients can have photosensitive dermatosis. Very, very nice. And this will be the last question. A 20-year-old patient presented to emergency with a widespread lesions. Patient was started on anti-epileptic drug phenytoin 1 week back. Which of the following statement regarding this is wrong? Which of the following statement regarding this is wrong? Anyone? Very nice, all of you. Very well done, each and every one of you. Very nice. I think you all have understood this. The correct answer of this question is option number 2. Whenever a patient develops a drug reaction, what is the first thing? You stop that culprit drug. If you will keep on giving that drug, the patient will not improve. Even he can worsen up. So please remember the correct answer of this question is option number 2. Stop the drug, which is phenytoin here. You can get oral mucosal lesions, that is true. It is an emergency condition, definitely true. There is a risk of sepsis, fluid and electrolyte imbalances. You can get renal failure, ophthalmologic complication. Everything can be possible. And steroid is the mainstay. You can even give cyclosporin for these individuals. Just look at this image. Uh, just look at this image. You can very clearly see that majority of the part, more than 30% of the body surface area, it is getting exfoliated. This is the acute state, and this is the state of healing. If the same patient improves this, you can see some sort of healing in them, and that is what given here. Okay, that is what is given. And this would be the last question of the today's session. Very nice. Gold poisoning lead to exfoliative dermatitis that is treated by steroids. That is the answer. Thank you all of you for your patience listening. I request all of you to please subscribe this YouTube channel, that is Let's Crack NEET PG. We also have our Telegram group which is known as same Let's Crack NEET PG. If you like to subscribe Unacademy, please use this code Chesta10 to get 10% discount. Don't forget to press the bell icon so that you get all the notifications of my classes, and don't forget to give thumbs up to my video if you like it. Thank you. Good day.